Yes, my name is Ulrich Luhmann. I'm one of the senior scientists in the group of Professor Bainbridge and Professor Ali at the UCL Institute of Ophthalmology, and where we work together in trying to identify new ways of treating age-related macular degeneration. But before I'm going to start, I would like to take this opportunity also as a basic scientist or translational scientist to thank you all for showing such much interest in our work by just coming here and talking to us about what you like us to do research on. And obviously, I'm very pleased that so many people are interested in the topic I'm very interested and passionate about, the research into age-related macular degeneration. But the question which this talk's really, or the title of the talk is, I have wet AMD, is there any alternative to injections? And many of you might ask, why is a basic scientist or a translation scientist try to attempt answering that question? Why is not there a clinician up here and trying to tell you all about this? If you think about this question, initially it seems to be a very simple question, which we should be able to answer with a simple yes or no. But as a scientist, as you might expect, these simple answers are often not what we like to do. But let me try to do it anyway. Why do we use it in clinic? Mainly injections. And I would like to try initially to illustrate the problems we face with treating the eye. And then at the end of my talk, come to three approaches we use to try to overcome those problems. So currently, obviously, the answer to that question is no, because of course we use injection in the clinic because it's the best option to deliver treatment to you which is safe and as efficient as possible. So that's why we use the injections in the clinic. And I would like to really stress it's important to remember that we always try to deliver the most safe and most efficient treatment to you for the current condition, and in this case the wet AMD, where we target these abnormal blood vessels under the retina and try to block the leakage from those blood vessels, which is a harmful process to destroy the cells, which enables you to see. And by delivering this drug, which has been mentioned before, to block this vascular endothelial growth factor, which drives this vessel growth, we were able to have an efficient treatment to block this condition. And if we just hold back another little second and think about what has been achieved by this treatment, and because we were able to provide you with an efficient treatment to do that and really see very dramatic improvement and protection of the cells in the back of the eye. On the other hand, of course, there are complications associated with that treatment, especially many of you might even know much better than I do how complicated it is to organize, to go every month there and to get reassessed, get an image, get a decision made whether we need another injection or not, and then even come back later to assess again whether this treatment was successful or not. And in that, possibly over years. However, we are really aware of that problem, and therefore we try to come to new solutions for that. And one of the questions we are trying to assess are the ways to reduce the number of injections you might need. And secondly, maybe can we even in the future deliver a solution which we don't need injections for, or maybe very limited number of injections. But before I go there and mention those approaches, I want to say something very important about the eye, because it's such a vulnerable organ and such a highly complex organ. It has been developed to be very well protected. It sits very protected under our skull or in our skull. And at the same time, it has a very physical barrier around it, which prevents any foreign substance to get into the eye, whether these are bacteria or even also drugs. So that's one of the reasons why we can't simply give you a pill you can take at home, for example, and swallow it. This drug needs to go through your whole body, reaches the eye, and then hits the barrier because it can't enter. So how do we overcome this physical barrier? And that's the reason why it's so difficult to develop a pill which gets straight to the eye and treats it. So alternatively, we could, of course, apply this drug straight to the front of your eye. But similar to the window in your house, the window of the eye, the cornea, the window of the eye, the cornea, is also very tight and sealed to prevent any bacteria or any stuff which drops onto the eye to get into the eye. So if you think about getting some dirt into your eye, you immediately start crying, we almost flush everything out, we start rubbing it. So that's one initial behavioral protection of the eye, but also the physical barrier of the whole cornea really prevents it getting in. So that's the reason why we overcome this barrier by injecting this drug into the eye, because this physical barrier overcome. But then another problem starts occurring immediately. Namely, also inside the eye, there are mechanisms in place which make sure that whatever breaches these physical barriers are transported out of the eye actively. So we can almost think about a constant stream of liquid trying to flush out any foreign substance from the eye. And that's one of the reasons why whatever drug we inject gets flushed out quite quickly, and there we have to reapply an injection after about a month. So how do we try to reduce the number of injections in the clinic then? And I want to mention two approaches which actually are tried for their safety already in the clinical trial. And the first one is the application of radiation to destroy these early vascular active lesions in the retina, which has been made possible by recent advances to apply radiation relatively focal and relatively safely to a very, very specific spot in the back of the eye. And of course, we combine that with injections. And recently, there was reports after a one-year trial study, about 230 patients performed at King's College, together with many centers across the world, where after a year of looking at those patients, there seems to be the possibility to reduce the number of injections by first destroying this lesion and then seeing how many injections do a patient needs after that over a year. And indeed, it seems that the number of injections has been reduced to 2 a year rather than receiving in the control group 3 or 4 over the year, time of the year. The second approach I want to mention is a gene therapy approach, because it has a huge potential to possibly provide a drug by a single delivery to the eye, and solves also the problem of the flushing out of the drug out of the eye, because we make the cells inside the eye by producing the drug itself. So we constantly produce the drug inside the cell at the right position in the back of the eye, where the development of these abnormal blood vessels occur, and don't have the problem that being flushed out, because it is constantly produced and produced again. So we should, theoretically at least, have a long-lasting effect of that drug in the eye by a single injection. And that's what our group is really intensely studying, and we try several approaches in animal models and in research models, but also I want to just mention a recent trial which has been started over the last year in Australia, and we are quite keen to await from a different group though, not by us, we expect these results to come out next year. But there was a recent presentation at a conference which I've been able to attend or see, and it was quite promising to see that these numbers of injections which have been used in these gene therapy approaches has been really dramatically reduced in the few patients so far which were analyzed in that study. And so, but I want to really make clear that these are really experimental treatments and in an early phase of a clinical trial where we really are currently in the process of showing actually that these approaches are safe. Not only for in this case, inherited degeneration, what we have done before, but also this is really interesting to see after a year of this treatment that there are obviously no dramatic side effects or damaging side effects to the condition. So that's quite a promising approach for gene therapy in that context. And finally, I want to just mention a very early finding in experimental models, which recently has come out of the Institute, where there was the potential to use even eye drops and deliver the same drug by tagging it with a molecular marker like an address label on the surface of that, or a little packaging provided. We can deliver with the eye drops on top of the eye. And these researchers have even shown in animal models that they managed to convince the window cells, let's say, to take this drug up into the cell and transport it to the inside of the cell. So that would be quite revolutionizing if we could give you those drops at home and you could apply them. But of course, these were really controlled experimental conditions in the lab. And we don't know yet whether this is actually also helpful for the clinical situation, and especially we don't know yet whether it's as efficient as the current injection route. Because as I mentioned before, we have this constant flushing system which drives drugs or foreign bodies, substances out of the eye. So far, these are the things which I just wanted to briefly mention, and I think and I hope that this gives you a good impression how we try to approach systematically these problems we have, and hope to provide you new treatments in the future, which hopefully in a little bit further future, you'll be even able to apply yourself at home. And that would be, of course, the best solution. But unfortunately, we are still quite far away from that. And it's a time, and as we rightly hear about, this will also require investment into research to really make that happen, hopefully even quicker. So thank you for your attention, and I'm very happy to take questions.
Thank you very much. There's a question in the front here.
Are there any plans to have a clinical trial of Iodine?
As far as I know, it's not the work of us, so I can't really tell you, but I have seen the recent press release from the UCL webpage myself, and you might even see that online. So as far as I know, theoretically, there are certainly plans, but it depends on funding to move that forward quite quickly. So I think that's certainly a very important idea, yes. To test that. I have to just say a little bit word of caution because as I said, the eye constantly produces this flow of inside water really to drive these things to the front of the eye. So it's still not quite so clear whether we can really deliver it in efficient amounts this way to the back of the eye where actually the problem lies in age-related macular degeneration. But of course, that's very important to test.
Is there a similar trial in the States? I read about it online.
Whether there's a similar trial in the States like that, I think that was the question. I'm not aware of that, but maybe you are, Adnan.
There was a trial of a topical therapy to try and reduce the number of injections, and unfortunately it was negative. And it may just be that the amount of drug and the consistency of the drug is problematic. And so although drops are very attractive, what we find in other eye conditions such as glaucoma, that actually the compliance in real life is difficult, and actually many patients forget or actually have difficulty putting the drops in. And so although on one level it's something we'd all like to go to, in a vision critical disease we need to make sure when we develop drop treatments that are effective, we develop aids of compliance at the same time. So there have been trials on topical therapy. Unfortunately to date they have been negative.
Thank you.
Thank you. And there's a question right at the back there, I think, Toby.
I would like to ask how many injections can we go on taking if the eyes are stabilized, but the condition recurs again? And the other thing, these new devices, the gene therapy and others, will they work with the ongoing condition, or it's only with the new discovered wet macular degeneration?
So I think this is I would like to first say I'm not a clinician, so the first question is a little bit difficult to answer for myself. How many treatments can we do? So maybe one of you could answer that.
So, sorry.
Sorry.
So,
sorry for that.
For those of you who have never had an injection, which is probably the majority of the audience, the thought sounds horrific, but they're remarkably well tolerated. There are still patients from the original clinical trials started in the early 2000s, still being monitored and still receiving injections and still tolerating them now. So it is not a limiting factor in how many injections the eye can take. The reason, as I mentioned in my initial talk, we need to have longer acting treatments is because it's very difficult from the hospital's point of view and the patient's point of view to get the regular treatments that we need longer acting therapies. Every time we miss a visit, sometimes a patient gets a little step drop in vision that over years accumulates to a more severe visual drop.
Thank you, Iodine.
So maybe regarding the second part of the question, whether the gene therapy would actually work. We have quite encouraging results from our work from the inherited retinal degenerations, and where we certainly treat conditions which are also quite far advanced. So we, of course, because we apply these treatments because of safety reasons, initially in relatively severely affected patients, to make sure we don't cause additional loss of vision by the treatment. So I think that we achieved something in these conditions already by a gene therapy approach is quite promising. So I would say there's a good chance it might work. And also this initial data set which I've seen, which is obviously very, very limited. And so I'm very keen to see the results from the whole cohort. The cohort they recruited to the trial. It's about 40 patients with wet AMD. Was quite promising, because they really dramatically reduced the number of injections needed. And of course, in these trials, the patients are always monitored as well, and then treated additionally with the working treatment of injections. So one of the main outcome measures is really for this trial whether we can reduce the number of injections. And then we have to monitor how long it will last. So I think I'm very optimistic, but also keen to know the answer to that question myself, because that will tell us whether to invest much more effort into that development or not. Thank you.
I just wanted to know, what do we know about the secondary effects of the injections? So far, we have the injections for a few years, because we have to sign a form, don't we?
Yes, certainly.
Yes.
I mean, as I mentioned initially, the eye is designed to not let anything in. So whenever we breach these physical barriers, there is certainly a risk of introducing some kind of infection and so on. So that's why we also very make sure, and our clinical colleagues especially make sure, that there's a close follow-up and a close monitoring of these processes to minimize the risk of these secondary effects, like an infection could go into the eye possibly.
So there are predictable, quantifiable but finite side effects of any injection into the eye, and that can include the possibility of infection, bleeding and detached retina. Those risks are really very small, and as Adnan said, they are considered to be acceptable even in the long term. It's important to point out that many people with the condition have an underlying dry form of the condition, and the injections that are available at the moment cannot be expected to protect against that form of the condition, and that some people may, despite the injections, go on to develop progressive dry macular degeneration. There's a theoretical concern, I don't know whether Adnan would comment on this, that injections may have an impact in terms of accelerating the underlying dry degeneration. But the evidence for that is not entirely conclusive, I think.
So, so can I just clarify the question? Was it about long-term side effects in the eye you wish to ask, or?
No, it was in particular about the possibility of affecting the heart.
So, okay, so I'll address that very good question. So, the way these drugs work is they block a chemical called vascular endothelial growth factor. That's a chemical released not just in the eye, but throughout the body, that tells blood vessels to leak and grow, but also probably has other functions. And the way these drugs were originally licensed was to treat blood vessels leaking, not in the eye, but in cancers. And if you can starve the cancer of its blood supply, the hope was you could stop the cancer growing. And in very large doses in the arm to treat cancers, there was a few percent excess risk of clots in blood vessels in the patients who got this class of drug. When we give it in the eye, we give a tiny amount, but we know a fraction of that leaks into the blood, and if we measure the levels of that chemical in the blood, they are slightly reduced. Less so with the licensed drug than the unlicensed version of the drug. In the original clinical trials of thousands of patients, there was no excess risk of heart problems, and people actively looked for it because theoretically it would be possible. In one subsequent trial, there was a suggestion that in patients who had the higher dose of the drug, there may have been an excess risk of stroke, not heart disease, in patients who had had recent strokes. After 2 years of follow-up, that difference was negligible. So it's a theoretical concern in patients with recent cardiac disease or strokes, and that's something we weigh up the risks and benefits. Because if it's your only eye and you don't treat it and you lose vision, the stress of that can precipitate a heart attack plus the risks of falls. So it's something we always have a discussion with the individual to weigh up the risks and the benefits versus the theoretical risks. Very good question.
Thank you very much. It makes it very clear.
And we have one more question here. 2 questions here. Thank you.
I've been a patient at Moorfields for many years, and used to receive, I don't know how many years now, monthly injection of Lucentis. And now for the last, I don't know exactly, maybe less than a year, I only have to go every 8 weeks to have an injection, the name of which I haven't got in my head.
It's Eylea, I guess.
What is it called?
Eylea, I guess.
Eylea, yeah. And so is it supposed to have the same effect as the Lucentis, or?
It is a drug which targets a similar pathway, but affects additional pathways as well. And the main role of that is that it's thought to last longer, and that's why the interspace. So that's another approach which I didn't really mention too much, because theoretically, of course, we can extend the half-life and the activity of a drug and try to improve that. And this drug has been designed to do that. So there's a more stable and binding of the chemical which produces the blood. So switching from the previous version of the drug to this compound helps hopefully reduce the number of injections by making the binding stronger, by affecting additional factors, and by lasting longer in terms of the effect. But as you can see, it's from 1 month to 2 months and very close follow-up. It's fantastic, but theoretically halves the number of injections you require. So that's a good promise, but of course we now need to build up new evidence how safe and how long-term that is. There is, of course, all done before it be used in patients. There is these safety studies done, so it's safe and good. But whether there are long-term other effects, we don't know yet about. We will have to follow that up.
My left eye's definitely got much worse, but over the years. But that's normal, I guess.
Thank you. And there was a question here. Another question here. Thank you.
In view of the barriers around the eye to keep out foreign matter, is there any point in taking an antibiotic after an injection to fight any possibility of infection?
Absolutely, yeah. Antibiotics are routinely used after injections into the eye to help minimize the possibility of a sight-threatening infection. Yeah, thank you.
You were mentioning the intense barriers around the eye that prevent...
I assume it's drops and...
any foreign matter coming to it.
So the biggest risk for getting an infection is actually at the time of giving the injection. We sterilize the eye with usually an iodine-based substance, and that's the most proven treatment, is actually because of the active injection. The little tiny hole, the bugs can creep in through that. The iodine is the most proven thing. We traditionally have given antibiotics after, but they're probably less effective than the iodine. And in very large studies in the States that have recently come through, there doesn't seem to be any additional benefit of the antibiotics after than the iodine given at the time. And many centers in the States and in Europe have actually stopped the antibiotics but have continued with the iodine with the same infection rate.